Once again, welcome and thank you for standing by. At this time, all participants are in a listen-only mode until the question and answer session of today's call. At that time, if you'd like to ask a question, you may press star 1. Today's conference is being recorded. If you have any objections, please disconnect at this time. I would now like to turn your meeting over to Dr. Patricia Powell, Deputy Director of the National Institute of Alcohol Abuse and Alcoholism. You may begin. Thank you.
Good afternoon and welcome. The National Institute on Alcohol Abuse and Alcoholism, also known as NIAAA, is the lead federal agency for research on alcohol and health and the largest funder of alcohol research in the world. Fetal alcohol spectrum disorder, or FASD, is a significant public health problem, and strategies to expand screening, diagnosis, prevention, and treatment are needed to address it. Research on FASD is a top priority for us at NIAAA, and NIAAA supports a large research program to prevent prenatal alcohol exposure, improve diagnosis of FASD, better understand the effects of alcohol on the unborn child, and develop effective interventions to mitigate the health effects on individuals with FASD. NIAAA's efforts also include studies to characterize the extent of FASD in the United States. The current study was conducted by the Collaboration on Fetal Alcohol Spectrum Disorders Prevalence, known as COFASP, consortium, which was organized by NIAAA to estimate the prevalence of FASD among U.S. school children. For today's teleconference, our presenters include Dr. Kenneth Warren, who is a senior advisor to the NIAAA director and a leading expert in FASD research, Dr. Marcia Scott, who is a health science administrator in NIAAA's Division of Epidemiology and Prevention Research, and she oversees the COFASP grant program. We also have with us the principal investigators on the study described in the JAMA paper. Dr. Philip May is a professor at the University of North Carolina Nutrition Research Institute and a leader in the field of FASD. Dr. May pioneered the methods known as active case ascertainment that were employed in the JAMA study during his research in South Africa. Dr. Christina Chambers is a professor of pediatrics at University of California, San Diego, and the director of clinical research for the Department of Pediatrics at UCSD and Rady Children's Hospital. Mr. Tom Donaldson is president and CEO of the National Organization on Fetal Alcohol Syndrome, also known as NOFAS, and he has been associated with this organization for over 20 years. NOFAS aims to prevent fetal alcohol exposure and works to educate the public, practitioners, and policymakers about the dangers of drinking alcohol during pregnancy. Now it's my pleasure to turn it over to Dr. Ken Warren.
Thank you, Dr. Powell. And I'm going to begin by giving a little background on both fetal alcohol syndrome and fetal alcohol spectrum disorders. And for the benefit of those who may not know, fetal alcohol spectrum disorders are a range of birth defects that are caused by prenatal exposure to alcohol, and they are the leading preventable cause of developmental difficulties in the U.S. and in many other places. The most severe end of the spectrum is called fetal alcohol syndrome, which was first recognized and named in 1973. Fetal alcohol syndrome has 4 characteristic features: growth deficits, a unique cluster of facial features, a small head circumference, or what is called microcephaly, and characteristic deficits in cognition and behavior. And in addition, there can be other organ as well as skeletal defects present in FAS and, of course, in the spectrum as well. In fetal alcohol spectrum disorder, this differs from the full fetal alcohol syndrome in that some, though not necessarily all, of the deficits are present. The prevalence of fetal alcohol syndrome as well as the full spectrum fetal alcohol spectrum disorders has remained unknown in the U.S. because their key features are not easy to recognize, and this limits the ability to diagnose both the full spectrum as well as fetal alcohol syndrome itself. This is a distinction from many other birth defects like Down syndrome and spina bifida. The prevalence of those disorders can be determined through clinic reports and through birth defect registries, but FAS and FASD cannot be accurately determined through such registries. However, our researchers have developed an approach to overcome the limitations of such passive reporting systems by employing a more direct assessment method. Called active case ascertainment, it involves screening of all children at school entry using physical, behavioral, and cognitive assessments, as well as maternal interviews to assess drinking history. This approach was first developed for studies that we undertook in South Africa and then undertook in Europe, in some locations in Europe as well. As we had determined accurate rates for FAS and FASD for sites outside the U.S., we judged that it was very timely as well as very important to next move on to the U.S. and identify the prevalence rates within communities and across the U.S. Now, Dr. Marcia Scott will further explain the study.
Thank you, Dr. Warren. The purpose of the Collaboration on Fetal Alcohol Spectrum Disorders Prevalence, or the COFAS Consortium, is to determine a more accurate FASD prevalence among general communities in the United States. In 2010, NIAAA established the Collaboration on Fetal Alcohol Spectrum Disorders, COFAS Consortium. The overall goal of the consortium was to develop a standardized diagnostic system to evaluate and report clinical characteristics of fetal alcohol spectrum disorders among affected school-age children and to establish prevalence rates. COFAS comprises a multidisciplinary research team led by Drs. Christina Chambers and Dr. Phil May. Participating communities were selected in the Midwest, the Rocky Mountains, Southeast United States, and the Pacific regions. And the goal was for the selected samples, to be more reflective of the United States population in previous studies investigating the prevalence of FASD. The new study, reported in JAMA, Prevalence of Fetal Alcohol Spectrum Disorders in 4 U.S. communities, is the result of these efforts. I will now turn the discussion over to the 2 lead authors of this paper, Drs. Phil May and Christina Chambers.
This is Philip May. We had 2 major aims in the COFAS consortium. One was to do what this JAMA paper has started, and that was to estimate the prevalence of fetal alcohol spectrum disorders in these 4 communities. The second aim of the principal investigators in COFAS was to define the characteristic traits of children with fetal alcohol spectrum disorders in the general population of the United States. That particular aim will be spelled out in much greater detail in the coming years as we are able to analyze the data, summarize it, and get it through peer review and published. So in estimating the prevalence of the full continuum of FASD, we used active case ascertainment, as Dr. Warren said, and we used a cross-sectional design among first graders, and we were looking for children with fetal alcohol spectrum disorders between the years 2010 and 2016. Children were systematically assessed in the 4 domains that Dr. Warren described, and each of these domains contributes to fetal alcohol spectrum disorders and helps to define where the children fall on the continuum. So based on dysmorphology, based on their growth and physical growth and development, based on their neurobehavioral development, and reports of prenatal alcohol exposure, the final classification was made along the diagnostic continuum of FASD. As Dr. Warren mentioned, the four regions where the communities were the Rocky Mountain region, the Midwestern, the Southeastern, and the Pacific Southwestern regions of the United States. All children were entered into the study by permission from their parents and guardians, and that permission was written. Approximately 60% of the parents and guardians in the four communities and in the 8 samples gave their permission for the children to participate. The results were that we screened 6,639 children who were from the particular population of first graders, which totaled 13,146 first grade children. Their mean age was 6.7 years. They were almost 52% boys, and a total of 222 cases of fetal alcohol spectrum disorders were identified among this population of over 13,000. We did 2 samples in each site, and there were differences by sample and by site. In other words, 2 first-grade classes were sampled in each site, so those constituted the 8 samples. The rates were found to be highest, the rates of FASD were found to be highest in the Rocky Mountain region and the Pacific Southwest, and they were the lowest in the Midwest and Southeast. So overall, the minimal prevalence of fetal alcohol spectrum disorders range from 11.3 per thousand to 50 per thousand in the 8 samples. Then we applied a weighting procedure, which was based on the particular conditions with which we gained access to the children, and from that weighted prevalence, further estimates accounted for those children and the weighted rates that we felt would account for how many fetal alcohol spectrum disorder children existed in the non-consented population. So with those higher estimates produced by the weighted prevalence, the estimates for fetal alcohol spectrum disorder range from 31.1 per thousand to 98.5 per thousand children. So with that, I think I will turn it over to Dr. Chambers, and she will discuss the maternal risk factors that we have explored and a number of implications.
Thank you, Dr. May. So just to follow on what the 3 speakers have said prior to this, I wanted to add a little bit more detail about the rigor with which this study was conducted. In the 3 domains plus growth where we evaluated these children, I think it's important to recognize that in the dysmorphology aspect of this, as Dr. Warren says, these features are not easily recognized. And so we had a team of expert dysmorphologists, geneticists who are extremely experienced in this area and have worked on previous studies of this type, who actually did the face-to-face physical exams using a standard checklist and seeing the children face-to-face in their school setting to be able to determine whether or not they had the characteristic physical features plus other features that are seen more commonly in children with prenatal alcohol exposure. And they did these exams blinded, too, so they were not aware of whether the mother drank in pregnancy or whether the child had any neurobehavioral deficits. Similarly, with the neurobehavioral domain, we selected a battery of tests a priori that would be appropriate for a child 6 to 7 years of age for a single testing evaluation, since we didn't have the luxury of being able to test the children multiple times over time. and would elicit information on key domains that have previously been identified as affected by alcohol. And then finally, the domain of maternal alcohol exposure. This was key to the study, and this data was collected by maternal interview, conducted either in person or by telephone by experienced, trained interviewers who went through a rather lengthy set of questions about demographics and pregnancy history and so on about each one of these mothers, and some extensive list of questions about current alcohol consumption prior to pregnancy, prior to recognition of pregnancy, and then during each trimester of pregnancy, with questions carefully phrased to be able to elicit what we think is valid and honest responses about quantity and frequency of alcohol. And then last, I wanted to say a word about the criteria for classification that were selected a priori before these classifications were made for fetal alcohol spectrum disorders as being the most appropriate for an epidemiologic study of this type in the general population. So not a sample of children coming into a clinic who'd been referred, but a general population sample of children in the first grade in school. And as Dr. May said, we found variations in the rates by site of fetal alcohol spectrum disorders, and also found variation in the manifestation or types of deficits that children exhibited in the individual classifications. And we think this is an important area to be able to pursue, to take a deeper dive in looking at children who were classified in the alcohol-related neurodevelopmental disorder arena in terms of, in a general population sample, what do those characteristic deficits look like? So it's in terms of future plans for this study, this was obviously the primary result of the study, but there are many other important details and learnings that we can gather from the data that families and teachers and schools were willing to collaborate with us to produce. Dr. May mentioned that we're next looking at the maternal and child characteristics by site. So what do these children look like, and what are the things about their mothers that might help us to understand who is at more or less risk. We have a very nice subsample of women in the studies across sites who agreed to provide some dietary information, so completed 24-hour dietary recalls of everything they had to eat or drink over a period of time, and we'll be doing an analysis of that to see if there's any evidence that mother's diet and specific micronutrients in her diet may be a modifying factor for fetal alcohol spectrum disorders if the mom drinks. And we'll also be looking carefully at the role of growth. So children who were or were not growth deficient on weight, length, or head circumference, or a combination thereof, and how that relates to the neurodevelopmental outcomes. Last, I'd like to say a word about the implications of the findings. To follow on what Dr. Warren said, we think this is an important study from the standpoint of representing a broad, diverse sample of children from 4 different regions in the U.S., and that it represents a general population sample as opposed to a clinically referred sample or a sample of children who are receiving services for special needs. So important from the standpoint of what that means for the general population at large. I think it's also important to note, as we did in the paper, that of the 222 children who met criteria in this study for fetal alcohol spectrum disorders, to our knowledge, only 2 of those children had previously received a diagnosis of FASD, which is consistent with some data that had been published earlier, suggesting that as many as 80% of children with fetal alcohol spectrum disorders go unrecognized, misdiagnosed, or not diagnosed at all. And then finally, we think the implications are important in terms of the public health impact of this disorder, that the rates of FASD are at least as high or higher than what has previously been reported for another neurodevelopmental disorder, autism spectrum disorders. And then finally, in terms of future directions, Dr. May and I agree that we hope that this leads to a call to action, that there is a need for broader access to and availability of clinical services for children with an FASD, and for school-based improvement in knowledge and how to provide services for children with these specific types of deficits. There's also a need for earlier diagnosis. So the recognition that only a very small number of children in this first grade sample had a previous diagnosis tells us that we have a huge opportunity to be able to provide a way to identify children at a younger age when interventions may be even more beneficial. And then finally, we think that this study points to the really critical need for better and more effective prevention efforts. And I will end there.
Hi, this is Tom Donaldson with National Organization on Fetal Alcohol Syndrome, NOFAS. I want to begin by saying thank you to NIAAA, Dr. Powell, Dr. Warren, and Dr. Scott for supporting and leading COFAST, and of course a thank you and congratulations to Dr. May and Dr. Chambers and to your colleagues for really this truly landmark study. I would add also thank you for your careers of discovery that have been so important to the FASD cause. Now at NOFAS, we've been working for 28 years to raise awareness about the risk of prenatal alcohol exposure and to support children and adults living with FASD, while at the same time also supporting women and their partners with alcohol use disorders, especially, of course, women who are in active addiction and are unable to avoid alcohol when pregnant. Of course, the challenge of gaining attention and public and private investment for FASD that is equal to what we now know to be its significance, it begins with the research, well-founded research. I think we've all seen that because of the hidden nature of the disabilities, some have continued to believe that FASD is a rare disorder or they question its prevalence. I would say this research really once and for all firmly establishes the magnitude of FASD, and that is such a critical point. Now it's really time for advocates and advocacy organizations like NOFAS and, for example, our 32-member affiliate network. But maybe most importantly, for disability advocates and others beyond the FASD community, it's now really time for us to push forward and make this study the catalyst for change and progress. Now, I believe the research is really the ultimate statement of need, and advocates must use it as the basis for everything from funding proposals, public health advisories and messages, policy and legislative advocacy, education and training in the schools and the justice systems, and of course in all medical and behavioral systems of care. And I also never want to miss an opportunity to say we have to advance alcohol screening in clinical settings and improve access to therapeutic rehabilitation for women of childbearing age who have an alcohol use disorder. In fact, a little plug, NIAAA has an online treatment navigator that is an important tool to find help in this area. I think the good news is there are many who are doing important work. The FASD prevention team at the Centers for Disease Control and Prevention, they're reaching discipline-specific practitioners and supporting the needs of families. I think their mandate is even more important given these findings. I mentioned the NOFAS affiliate network. These are organizations in our communities, meeting the real-world needs of FASD. These findings, this data, enhances their authority, and they need to be using that and will to get greater attention and support. The real advocates, though, are the families, and we all understand that they don't need this or any research to tell them how often FASD occurs, and that it's usually overlooked and there's a lack of services. I think all of us, as scientists and advocates, all of us have to stand with the families and really demand recognition and services. I think this paper, this study feels like an important milestone, that gives us the science and therefore the justification to do that, to insist on services, to insist that individuals with FASD are eligible for services at all levels. So again, as an advocate for this cause, this is a landmark and it is a milestone without overstating it.
Hi there. We're now going to open it up to questions.
Thank you. At this time, if you'd like to ask a question, please unmute your line, press *1, record your first and last name when prompted. If you need to withdraw from a queue, you may press *2. Once again, in order to ask a question, please press *1. Give us a few moments, please. Our first question comes from Laura Kelly. Your line is open.
Hi, thank you. Can you hear me?
Yes.
Thanks. So I had two questions. The first is that I think I read in the press release that this is the first time these criteria were used to evaluate possible FASD in children. So is this new and novel criteria that would expand the children that would be diagnosed, which is why maybe we have a higher number? And then my second question is, do you have any more information on the mothers of the 222 children that were diagnosed, maybe their rates of alcohol consumption during pregnancy?
This is Dr. May. Actually, the criteria or the guidelines that we use to diagnose these children actually were created in 1996 by a committee of the Institute of Medicine of the National Academy of Sciences. Over the years, my research team has been working with these guidelines, improving the criteria used, and the COFAST actual cutoff points for each of the criteria were refined from those criteria that have been worked and over and reworked for many years. So no, these have been used all over the world in multiple studies. In my own studies, we've used them in at least 20 other samples of population-based studies. So no, they were not used. They were not new and used in any different way from many of those other studies.
Okay. And this is Tina Chambers. I think the question I heard you ask at the second part of that was the level of alcohol consumption. So I think we did capture quantity and frequency and timing of alcohol consumption in pregnancy, and then we used a criteria for a cutoff of what we called risky alcohol consumption that's laid out in the supplemental materials for this paper that required that the mother report at least 2 binge episodes, quote unquote, of 3 or more drinks per occasion during pregnancy, and or at least 6 or more drinks per week for 2 or more drinks during pregnancy, or we allowed for documentation of alcohol-related social or legal problems as a proxy for that type of exposure. So we do have data that will be coming out as part of these maternal characteristics publications that are in the queue that will describe the level of self-reported alcohol consumption in these mothers who did or did not have children who were classified as FASD.
Thank you.
Along with a lot of other distal factors as well, as including other drug exposure, a number of pregnancy variables, nutrition, as was mentioned earlier by Dr. Chambers, et cetera. So we'll have quite a bit of information on the mothers of both the children with FASD and the children who were found to be typically functioning.
Next, we have Bonnie Rubin. Your line is open.
Thank you so much for taking my question. I think my question might be best directed to Tom Donaldson, but certainly the researchers, if they've got some thoughts on it, can pipe in as well and give their 2 cents. So as a parent, I'm always interested in where I can find the best help for my kid. And you said you thought this study, this landmark study, could be a catalyst for, funding proposals for the justice systems, for schools. Can you share with us the disinvestment or the actual funding cuts that you're aware of that have occurred in recent years? For instance, I think the SAMHSA site was shut down, the Center for FASD Excellence, which was a wonderful resource for parents. The second part of that is, just as tobacco companies have been the biggest funders of anti-smoking programs over the years, do you think this study will help get alcohol, distillers to contribute to services and interventions for what we know is, a very large swath of the population that has contributed to, homelessness, unemployment, addictions, and certainly the incarceration rate. So first, what has happened in recent years in terms of money, and then anybody's feelings on whether distillers or alcohol companies can be allies.
Thank you for the question. I know certainly when talking with policymakers and those who make funding decisions, we've seen that perhaps the first thing they inquire about is, well, how often does this occur? And that has been a challenge to answer that question directly. So I certainly feel that this gives us something more and to be able to have that conversation and to be able to demonstrate the necessity of attention and investment. Unfortunately, it is true that over the last half a dozen years, 4 to 6 years, from a federal standpoint, there are fewer dollars specifically allocated to FASD. And you pointed out the Substance Abuse and Maternal Health Services Administration, SAMHSA, no longer has allocated money for FASD. Fortunately, the CDC continues to work on this as they have for 20 years, and NIAAA for 40, 45 years, without a specific line item, but with a dedication within the Institute and a belief that this is a very significant issue, they've continued to support in a significant way the behavioral and biomedical research. Yes, I hope that we can turn things around, and not just here in Washington, but more broadly among private institutions to support this issue. In terms of the alcohol industry, yes, we all like to have them involved. NOFAS has always maintained a dialogue with the industry and encouraged them to support prenatal alcohol exposure as they do with underage drinking and driving. It's been a challenge because this issue has not something that society has deemed on a par with those causes to this point. It can take a generation or more to do it. We continue to work towards that. The industry will point out that there is a label on all containers of alcohol sold in America that mentions this issue. That's obviously not enough. There's been some success, and I think we have to continue the dialogue with the industry, encourage all levels, from the trade associations to the manufacturers, suppliers, and so forth, to address this issue.
Thank you.
Next, we have Carolyn Kremley. Your line is open.
Yeah, hi. First, I'd like to say thank you for this great research that helps us to pin down actual prevalence. I do have a question about if you have any sense of the effect. This was, as I understand it, done in public schools, and I'm wondering what the effect is of evaluating at first grade level in a public school and how much you might lose by not looking at private schools, home schools, or regional center settings. If you have any sense of, my sense is that you probably have a much greater prevalence than what you actually revealed, but I just would like to hear from the researchers how they feel about that.
Tina, I'll take this at first, and then you follow on if you don't mind.
Okay.
In two of the sites, the Rocky Mountain site and the Midwest site, all 4 samples included every single school in those jurisdictions, in those counties and cities. So we got every single public and private school, and those regions tend to have lower rates of homeschooling as well. So we did miss the homeschool kids, but we got all of the public and private. So in those 2 sites, I think we can say that it is a beautiful cross-section of the population. Now, in the Southeast site, we did not get private schools. We did not approach them for a variety of reasons, and I might also point out that the Southeast region doesn't have a huge representation of private schools anyway. So we missed the homeschoolers there, too. Now, Dr. Chambers can tell you about the Pacific Southwest.
Yeah, so a really good point. And in the Pacific Southwest, we not only had to select schools within the public school district because there were just too many to be able to do the entire number of elementary schools. We did invite private schools to participate, and we had one that participated, but certainly not every private school in the area. And we didn't have ability to access children who were being homeschooled. So I agree with you that if we had to guess what the impact of that was, that we might be missing children who might be at higher risk of FASD. We did have a subsample in Pacific Southwest of regional center clients, and we didn't include those in the school sample because obviously they were selected by virtue of receiving services. And for those on the phone who don't know what regional center is, that's the mechanism in California where children with some kinds of developmental disabilities receive services. So we will be looking at that separately, but that will give us an idea, at least in one special population, of what the prevalence might be there.
One other point that I might add that speaks to the general representative nature of these samples, at 3 of the sites, in each of the 6 samples in those sites, there was no difference in distribution of FASD based on race or ethnicity. That is, that the rates were there was no significant difference in the rate of FASD prevalence over that what was expected by their general representation of the population. So there really was not racial or ethnic variation that showed up statistically.
Thank you.
Next we have Valerie Lippo. Your line is open.
Good morning. It's nice to hear your voice, Tina. You're probably right down the hall from me. My question has to do with individuals in the United States who are not just beginning public school, who may have gone under the radar because their behavioral symptoms are confused with other neurobehavioral conditions such as ADHD, or they simply are assigned an emotional impairment or some other issue, post-traumatic stress, a reactive attachment, or any other condition that the people who are looking at behavioral conditions don't recognize fetal alcohol spectrum disorders. And as a parent, I can tell you that this happened in my case because my son was not identified by anyone, pediatricians, psychiatrists, psychologists, school personnel, anyone, until he was in juvenile hall in San Diego County, and the corrections system there suspected that he fell under the spectrum, and by that time he was almost 17 years old. So I'm wondering if this research is going to be replicated, looking at, say, for example, children entering grade 6 in the United States, or entering grade 9, or those who have dropped out of school before grade 12.
So, Val, this is Tina. I think I can respond a little bit to that. We, of course, would have loved to be able to look at a cross-sectional sample of children at various ages, and for sure, recognizing that what we may pick up in a 6 or 7-year-old may miss deficits or difficulties that children may be having when they're 10, 11, 12 years of age. We sort of chose this as the sweet spot of the combination of being able to look at children before maybe they weren't diverted off into other settings and we're just starting school, but also we're old enough to be able to test them in the domains that we think might be affected by alcohol. This was not a longitudinal sample. Certainly there would be benefit in being able to follow up those children who were identified to older ages, as well as children who were not identified to older ages, to see what the sort of underestimation might be, presuming that would be the case. But for the purposes of this study, to be able to estimate in the first grade in school at the earliest age that we thought we could get good measures on the neurobehavioral testing battery and get a general population sample, that was the choice that was made. And I agree with you, those comments that you make are very, very relevant.
If I might chime in too, I agree with Dr. Chambers, and I know that that you would probably share this opinion too, but longitudinal studies are the best way to look at that, because in NIAAA-funded studies in South Africa by my colleagues, by my team, and in Ukraine that Dr. Chambers has going, the symptoms, the traits, and the behaviors do change quite a bit in each individual child from birth to the teen years. And so that would be the best way to look at it. And then if you start with a good cross-section of the population in those longitudinal studies, follow them from the prenatal period, collecting good data on the mothers and the children over time, that would be the best way, I think, to answer the question that you're asking.
I don't know. Am I still on? I don't know whether I am or not.
Yes.
Okay, well, maybe I didn't make myself clear. In my mind, a longitudinal study has to do with looking at the same cohort of subjects over time, and what I was suggesting is using the same protocol that you have, but identifying, going into different grades and looking at new individuals and trying to identify if you're going to capture more, the same, or fewer candidates for diagnosis because of their socialization, or whether if they become more, their behavior becomes more unlike those of their chronological peers the older that they get, which is what, as a parent, what I noticed. I don't think my son would have been diagnosed if he had been looked at for fetal alcohol issues when he was 6, but by the time he was in middle school, if we had known what we should be looking for, we probably would have gotten closer to it, because he behaved much less like his chronological peers by that time.
Well, both Dr. Chambers and I mentioned two ways that could be done, and so you seem to be coming down on the side of repeated cross-sectional studies, and that is certainly a good way to do it, and we could go back and look at children at other grades. The other way is the way I mentioned, the longitudinal studies, where you would have, in the longitudinal studies, you would have both exposed and unexposed children to various prenatal exposures, various toxins, if you will, like alcohol, and you would follow them throughout, both the unexposed and the exposed children, and that would give you the same kind of information as a whole series of cross-sectional studies, and the information would be on the same exact children at each age.
Right. But as speaking as a parent, it would take a heck of a lot longer. And I guess what my concern is, and my dream research would be, that you would take the state of California where I live, and because the population of California is approximately the same as the population of Canada, and sort of compare what is learned about cross-sectional studies or longitudinal studies in the population of California compared with what has been identified in the population of the various provinces in Canada.
Next we have Joanna Jones. Your line is open.
Hi, this is Johanna from Memphis, Alabama. Thank you so much for taking my call. And I was curious to know about any type of studies that will be on the same population on maybe treatments with that same population. Is that in the pipeline or a possibility? And I don't know, maybe a longitudinal study could be for that, since it would kind of measure over a time period.
So, Joanna, this is Tina Chambers. I can say in the Pacific Southwest site, we had the opportunity to be able to offer an intervention that had already been vetted and shown to be successful in children with FASD. We didn't do it as a research activity. It was really as a sort of a way to offer something for the children and families where the child exhibited deficits that might be amenable to this intervention, whether or not they were due to alcohol. So we did have some families participate in that. It's the MILE intervention, the Math Interactive Learning Experience. Seems to help children at those ages who are having difficulty with certain types of learning problems, and I think that was well received. I think in terms of establishing or developing interventions and implementing them in the school system, would be a phenomenal goal of researchers and people in public health and education as well.
And there are some studies that have been done by both in the United States and other countries that have looked at interventions. Very few with very young age children, but there are other interventions like that come out of UCLA, some up in University of Washington, that actually can give you some insight as to what seems to be effective in a few limited realms, and then where we might go with future interventions.
Next, we have Diane O'Connor. Your line is open.
Thank you. Hi, it's Diane O'Connor from New York. My question is, how do we get, now I'm hearing that Dr. May and Dr. Chambers use the specific 1996 criteria to evaluate, but over the years you've modified it or tweaked it a little. How do we get that diagnostic guidelines to local clinics and doctors? Yesterday, I still had a doctor say, I won't give a diagnosis of FAS because there is no services. Yet I've been working hard for the last 25 years to make sure that families get hooked up with services. So how do we get what Dr. May and Dr. Chambers know? How does that get out to the physicians who are on the front lines doing this kind of work, they're still not making that diagnosis.
Well, the specific updated guidelines that we used in COFAST were published in 2 places so far. That is the exact criteria. They're in a paper in Pediatrics in 2016. Those particular cutoff points and diagnostic criteria were developed as part of COFAST. So we had multiple disciplines come together, take the 2006 updated guidelines, and that was published in Pediatrics under Hoyme et al. And many of the people who contributed to that all of them were part of the COFAST effort. Secondly, there is a statistical appendix to our JAMA paper that you can access online, and that has the updated criteria, test battery used, physical exam criteria, and alcohol cutoffs that Dr. Chambers pointed out earlier.
I also want to add that I think also what you're getting at here is the reluctance on the part of the general pediatrician or clinician to assign a diagnosis to a child if they don't know what to do with that child, any different than what they otherwise would do. And that is a big issue. Our hope is that one of the results or follow-ons of this paper being published is that awareness among pediatricians and other clinicians will be raised that this isn't something you see once in a blue moon or not at all, that it is something that you should be considering in your general patient population, and that there is benefit to providing the diagnosis. There may not be the perfect set of interventions or comprehensive ones that are developed yet, but there are interventions and there are tools that can be used to address the specific deficits that the child is exhibiting and may be likely to exhibit down the line, and that's an education process.
As a reminder, if you'd like to ask a question on the phone lines, please press *1, record your first and last name before doing so, and you need to unmute before doing so. And we have one last question. One moment, please. And I think that's Teresa Convoy. Your line is open.
Yes, hello. My question is for either or both Dr. May and Dr. Chambers. Have either of you thought about actually writing an opinion piece based on this study for a major newspaper, LA Times, Washington Post, to talk about the study but the impact and what this really means, in the real world, the impact on public health that is not understood by people now, but maybe if they can look at the projection of what this many first graders testing for these disorders is going to mean to rates of, issues and school issues, but, more funding for special education, more funding for mental health, more funding for addiction treatment, etc. So I'm just wondering if that's a possibility.
Tina, you want to go first?
I think it's a great idea. I think that the media coverage that has been generated by this paper, we've had the opportunity to say some of those things, and the commentary that was accompanied this article in JAMA pointed out some of those issues as well, but that it's important to be able to speak to those issues as frequently and to as broad an audience as we can to move this forward.
I agree that the Lang et al. Editorial that accompanied our paper in JAMA was an excellent start. There was also an opinion paper when a secondary data analysis study of the worldwide prevalence of FASD was published by Chudley et al., and I think those are good starts. But an opinion piece of that kind that is really targeted at the general population, I think, would go a long way, and or multiple opinion papers. And I agree completely with the range of services that you ask about, because if you look at the 3 to 8% or 1 to 10% of the children who are affected in the general population, everyone doesn't need a clinical intervention. It would be good if everybody got a clinical diagnosis, but that's probably not going to happen because it'll overload the system. Many of the children whose effects or deficits are at the lower end of the spectrum can benefit from special education and just some moderate interventions of those sorts. Now, they can be disruptive in a school system, but from what I have read and what my colleagues tell me, that some minor changes in classroom settings can have a big effect. So I think you hit the nail on the head that there are a variety of interventions that could be done. Some of them are very medical and clinical. Some are very psychosocial, but others are as simple as enhanced nutrition, music therapy, classrooms that are structured differently, individual attention that's targeted in particular ways, those sorts of things. So there's a great need to get all of that type of information on interventions out.
Great, thank you.
We will now have concluding remarks from Dr. Powell.
Well, thank you to all, and thank you especially to Dr. May and Dr. Chambers. As evidenced by today's teleconference, we have made many important advances in FASD research, but clearly more research is needed to fully understand the extent of prenatal alcohol exposure and to gain insight into the biological mechanisms underlying the deficits associated with prenatal alcohol exposure. So to that end, NIAAA will continue to support a robust and diverse portfolio of FASD research that aims to reduce the incidence of FASD and to mitigate the effects of alcohol exposure during pregnancy on children and adults. And importantly, we will continue to work with organizations such as NOFAST to get the research out to those who desperately need it. So thank you for joining us today. For more information on NIAA's research and regular updates on our projects, please follow us on Twitter at NIAAA News. Thank you.
Once again, thank you for joining today's conference. This now concludes your conference. All lines may disconnect at this time.